Word on Health, the report with its finger on the pulse of popular medicine, with Paul Pennington. Word on Health, for your very best of health.
Around 100,000 people across the UK are estimated to be living with facial palsy from all causes, with around 1 in 60 of us experiencing the commonest form, Bell's palsy, during our lifetime. Trina Neville is an extended scope practitioner, physiotherapist who specialises in facial palsy.
Facial palsy is a condition where the facial nerve, which is one of the cranial nerves that comes from the brain, is damaged in some way, and therefore half the face becomes paralysed. People can't close one of their eyes properly, their mouth doesn't work on one side of their face, and that can last anywhere from a couple of weeks to being a permanent problem for people, depending on what has caused the facial palsy in the first place. There are lots of different causes. The most common is a virus. It can be the herpes zoster virus, or it can be the varicella virus, which is the shingles virus, which causes a type of facial palsy called Ramsay-Hunt syndrome. However, facial palsy can also be caused by a host of other things. So Lyme's disease, tumours in the brain, trauma can be a cause. We get some patients who have skull fractures. There's over 60 different causes of facial palsy. It's just that viruses are the most common cause. 60 to 70% of people will recover within the first month to 6 weeks. However, there's a percentage of people who will have a much slower recovery and then will go on to develop something that is called synkinesis. And this is when the nerve almost over recovers itself. It becomes overactive rather than underactive. So at this point, people can have a situation where, for example, when they're chewing their food, their eye starts to close, or when they yawn, their eye completely closes, or when they're trying to close their eyes to go to sleep at night, their face gets incredibly tight. So they get almost the opposite problem of the paralysis, where they get this extreme tightness and overactivity of the face. Those are the sort of two main presentations of facial palsy.
Trina, how important is it that patients presenting with facial palsy are treated swiftly?
It's really critical that people receive the appropriate medical intervention within the first 72 hours, and the sooner the better, in all honesty. That would be mainly steroids to reduce the inflammation around their facial nerve and get the pressure off that nerve as quickly as possible. And in some cases, patients also need to be given antiviral medication as well, particularly if they have Ramsay-Hunt syndrome, or if they have significant pain they're presenting with at the same time as their facial palsy, then they should be given antiviral medication as well.
Dr. Simon Lowe, a retired GP and medical advisor to the charity Facial Palsy UK, shed some light on where some of the problems lie for those 30 to 40% of patients who don't initially respond positively to treatment.
The first problem, I'd say, is lack of awareness from GPs and diagnosis, so the importance of thorough assessment and appropriate early onset treatment. The problems then arise when patients don't respond. I can certainly remember times when I had patients come in a few weeks later after giving them steroids, hadn't responded. I was never quite sure what to do. Did I refer them to ENT? Did I refer them to ophthalmology? Did I refer them to plastics? I think there's a definite need for a standardized, inverted commas, template to be introduced across the NHS so that all can have a similar pathway. Another problem is definitely the fact that it's a lot of different conditions covering a lot of specialties. So which specialty should take responsibility for it? People tend to go to ENT or neurology. We know there are long waiting times for that, which is inappropriate for patients with these conditions. For the chronic ones, it's more the plastics and if it's eye, ophthalmology. But again, the waiting times are ridiculous. And when you're suffering day to day with problems around chewing, closing your eyes, speaking, you might have vertigo. It's definitely a neglected condition and really needs to be moved up the hierarchy of conditions. But of course, there's no specialty that's responsible for it, which makes it very difficult.
Coming back to you, Trina, when do you get involved in the patient's journey?
It's a bit of a shame that I have to say this, but most of our patients find their way to our specialist facial palsy service by doing their own research. So they've often contacted the Facial Palsy UK charity to say, help me, I don't know what to do. Nobody seems to know where to send me. And then they'll start doing their research as to where there are specialist centres and where they can be referred to. So patients have to do a lot of the legwork themselves. And obviously that takes time and that delays their access to the care that they need. We did a piece of research a couple of years ago that showed that patients who can access specialist care earlier are less likely to have complications related to their facial palsy further down the line, such as the severity of the synkinesis might be less if they've started their therapy earlier. So we're really keen that patients are able to access care as early as possible. Now, of course, we've already talked about waiting times in the NHS, and this is a really significant problem for us now, where we might say we would really want to see patients within the first few months of onset of the condition, because obviously a lot of people are going to make a full recovery. So we don't want to scare people. If people do have facial palsy, there's every chance that they will make a full and complete recovery. But for those people who don't, we want to pick those people up as early as possible. And sadly, in the NHS, there is quite a long waiting list for clinic at the moment. But in an ideal world, if people have not made a full recovery by the sort of 6 to 8 week mark, then we usually say they should definitely be starting to seek specialist care and intervention at that point. And usually those patients can just start with a specialist facial therapist. So once we've ruled out any sinister pathology and we know that there's nothing going on that needs acute medical intervention, then those people can be case managed by specialist facial therapists, and we can provide all the rehabilitation strategies that patients need to minimize any long-term complications that they might have.
The number of specialists with background and knowledge in this area of health are few and far between, which I understand you're trying to change through the training you provide.
Absolutely. There's not enough specialist facial therapists. The facial therapy paradigm spreads across all of therapies. So you will find that some facial therapists are physiotherapists, some are speech therapists. I even work with a girl who's an occupational therapist who has now been trained by us to be a specialist facial therapist. So patients can fall between the cracks in terms of therapy provision. And also for therapists, the face is not something, and facial palsy is not something that's covered at undergraduate level. This is the postgraduate specialism that needs additional and significant training. It doesn't follow the rules of normal musculoskeletal physiotherapy, whereby if you strengthen something up, it gets better. The face is a very gentle piece of equipment. There are lots of muscles that are connected to skin and interconnected with each other. And so often people are given generalized advice to do general gross movement exercises, which can actually make them worse rather than better, because people are assuming that the same thing should be done for the face as would be done for a knee or an elbow or a shoulder, when actually the face needs completely different management to the rest of the body. So I am the CEO of another charity, Facial Therapy Specialists International, and our charitable remit is to improve education for therapists internationally, to make sure that we can get as many therapists specially trained so that they can provide the appropriate care and intervention for patients across the world with facial palsy. So we provide a lot of courses, webinars, mentoring that's accessible not just to therapists, but also to all medics with an interest in facial palsy. Over the years, we've trained hundreds of therapists, which is really exciting. But of course, these patients need to get to these trained therapists in order to access their care appropriately, which can be challenging for them.
My grateful thanks to Trina, Neville and Dr. Simon Lowe. To find out more and to connect through to Facial Palsy UK, visit our wordonhealth.com website. That's wordonhealth.com.
Word on Health, for your very best of health.
All men who are in their 65th year or over are invited by the NHS for a safe, quick and pain-free ultrasound check that could save their life. On average, 80% of men do, but local health officials are keen to encourage the 20% that don't to come forward, given that around 1 in 70 men will have an abdominal aortic aneurysm, or AAA as it's otherwise known. Mathew Bown, British Heart Foundation Professor of Vascular Surgery at the University of Leicester, explains what a AAA is.
An abdominal aortic aneurysm is basically a swelling of the main blood vessel in the back of your abdomen. So the aorta is the blood vessel that carries blood from your heart to the rest of your body. And as it passes through the back of your abdomen, this is a common place where it can basically stretch up. And what happens is, as the wall of the aorta gets a bit thinned and weakened, it can't hold the pressure quite so well. So a bit like a cartoon hose pipe, you can imagine. Somebody stands on the hose pipe and the hose pipe swells up. That's really what an aneurysm is. It's a swollen blood vessel. And the main risk of these aneurysms, a bit like that cartoon hose pipe, is that if they get too big, they can actually burst and cause internal bleeding.
What are the risk factors?
One of the main risk factors for aneurysm is age. We don't generally see younger people with aneurysms, and the older you get, your aorta naturally gets a bit bigger with age anyway. It's most common in those over the age of 65. You can get it in younger people, but it's rare. If it does occur in younger people, then it's quite often due to a sort of true genetic disease, i.e. one of these diseases where you will inherit from your parents if you inherit a single gene. Women are less likely to get an aneurysm than men, which is why the screening program is for men only at the moment. For the more common types of aneurysms, those that really occur when you get beyond 65 or so, age is the main cause. And all of the other things we know about are things we call associations. So we know that aneurysms are more common in certain groups. We know that people who've smoked in the past or currently smoking are higher risk of having an aneurysm. And we know that men are a higher risk of having an aneurysm. If you look at all the research studies done, there's things like high blood cholesterol, high blood pressure, things like that have been linked to aneurysm, but it's not absolutely certain whether those risk factors definitely cause the aneurysm or they're just more common in people with aneurysm.
And we should add that abdominal aortic aneurysms can run in families. How do you grade and treat abdominal aortic aneurysms?
What we know is that the highest risk aneurysms are those that are the largest ones. And so basically what we do is we grade them by measuring the size of the aorta. We know that small aneurysms, and by small, what we really refer to are those that are less than 5.5 centimetres, that are very, very low risk of causing any problems through bursting or leaking. And so people with small aneurysms are just monitored over time. We save surgery for those people whose aneurysms are larger, where the risk of the aneurysm bursting and causing internal bleeding is greater than the risk of surgery. We have to acknowledge that surgery is very good, but there are risks with surgical procedures, and it would be much better if we could avoid surgery in people if possible.
I understand research that's been funded by the British Heart Foundation that you've been involved with may help further focus the abdominal aortic aneurysm screening program in future and potentially enlarge the treatment options available to clinicians.
What we've basically done over the last 10 years or so is we've collected DNA samples from a large number of people with aneurysm and also people without. And what we've basically done is we've compared the entire genetic information from all of those people with aneurysms to people without. And through that process, we've massively increased our knowledge around what are the genetic causes of aneurysm. And in particular, we've now started to be able to pick out some areas that look like they may be areas we can target to develop new drug treatments to see if they prevent the aneurysm progressing and hopefully preventing them needing to even think about surgery.
My grateful thanks to Professor Mathew Bown. To find out more, visit our wordonhealth.com website. That's wordonhealth.com.
Word on Health, for your very best of health.
Chronic obstructive pulmonary disease, or COPD as it's otherwise known, is thought to affect around 1 in 10 of the UK's adult population, including an estimated 2.8 million people that may have it but remain undiagnosed due to poor public knowledge and limited professional awareness. Mona Badafel is Professor of Respiratory Medicine at King's College London.
COPD is an umbrella term for diseases like chronic bronchitis, emphysema affecting the small airway. It manifests itself because of exposures in a lifetime, smoking being one of the most commonest exposure, but air pollution, work exposure, people report breathlessness, cough, increasing sputum or wheeze, and multiple episodes of perhaps what is termed as chest infections, but may be related to inflammation. We diagnose COPD by doing breathing tests, so spirometry, and you have to have a certain deficit, an obstruction deficit, or an obstructive picture. And by the time you get obstruction diagnosed by spirometry to be called COPD, you've probably lost quite a lot of your small airways anyway. People are thus often in their mid-50s to mid-70s by the time that they're diagnosed. That's not to say that they've only had the disease for a short while. They've probably had it for a longer time. It's just our tools aren't able to diagnose it earlier yet.
Are there genetic risk factors?
Alpha-1 antitrypsin deficiency can cause COPD and can be diagnosed in an earlier age. Early exposures, so we're even talking about exposures in pregnancy, potentially can affect the way the lungs grow. Exposures during early life, we know that prematurity or malnutrition can affect lung development. And we know that our lungs develop until the age of 25. So impact on lung development at all the ages before 25 are likely to have potential causes of COPD as well. The biggest global cause of COPD is actually exposure to biomass. This is where you're cooking in an unventilated home with woods, coals, fires indoors, and that's probably the leading cause of COPD across the globe.
You mentioned earlier smoking as a contributor to COPD. What about vaping?
We don't know as much as we do know about smoking and the effects on the lung with regard to vaping, but we do know some vaping causes different lung diseases, pneumothorax, for example. How it affects COPD is still something we need to still learn a little bit more of.
Is COPD a progressive disease?
I don't want to say that everyone progresses, but largely because there's a deficit that someone starts up with, maybe say in their 50s, we also then have natural aging, which leads us to have a lung function loss. And so that compounds the original deficit from COPD.
Where are things at in terms of treating it or curing it?
We haven't got any medicines that can reverse it just yet, but we have treatments that try and slow down that progression, such as inhalers, such as new treatments like biologics, and of course non-medical treatments like pulmonary rehabilitation, which are excellent ways of trying to stop COPD from getting worse.
As I can personally testify, COPD can have a significant physical, mental and emotional impact. Over the past 20 years, COPD has gone from the 5th to the 3rd biggest cause of death in the UK and is predicted to be the greatest cause of lives lost in the next 25 years. Why haven't we seen progress in this disease area like we've seen in others?
A really important question, Paul. I think as a disease of social deprivation and health inequalities, I don't think it's had as much funding as cardiovascular disease, for example. It certainly hasn't had a huge public campaign like stopping yourself from having a heart attack. And because not every single patient is the same, we've not been able to task ourselves in terms of the science to just look at particular groups. The studies enrolled patients, but treated them all as if they were the same thing, and they're not. So there's multitudes of things, really.
My grateful thanks to Professor Mona Badafel from King's College London. To find out more, visit our wordonhealth.com website. That's wordonhealth.com.
Word on Health, for your very best of health.
According to research released to coincide with the recent Know Your Numbers initiative, while 84% of adults recognise that high blood pressure can lead to heart attacks and 79% understand it's linked to stroke, a huge proportion of us still aren't taking steps to monitor our own health. Despite high blood pressure being the biggest preventable cause of death in the country, just under half of adults don't know their current blood pressure, a third don't check it regularly, and just 11% know that the over 40s should check their blood pressure once a year. Dr. Pauline Swift is from Blood Pressure UK.
From 16 onwards, certainly from 20, and from the age of 30 to 40, every single individual in the UK should be having their blood pressure checked. This is really worthwhile doing. The vast majority have no symptoms. If you don't, you won't know it's high, and then you won't have the opportunity to have it treated and controlled.
It's estimated that there are around 5 million people in the UK living with undiagnosed high blood pressure, and they just don't know about it. This, of course, increases their risk of stroke, heart attack, kidney disease, vascular dementia, and early death. What are the factors behind high blood pressure, or hypertension as it's otherwise known?
It's a complex mixture of genetics and environment. And the environment really that we're talking about here in relation to high blood pressure is diet. There is increasing obesity in children as well as adults, and an increased BMI is very strongly linked to an increased risk of high blood pressure. Salt is a major dietary environmental risk factor for high blood pressure, but it drives the blood pressure up, and it's an environmental toxin as far as I'm concerned, but it makes high blood pressure quite resistant to treatment. So it's very important to cut it out.
The best way of getting your blood pressure checked is through your GP or local pharmacist, who can give best advice on your reading. But we live in an age where we have wearable devices and apps for monitoring blood pressure. If we do want to buy one of these, how can we ensure we're investing in the right bit of kit that is properly validated for the job?
The Blood Pressure UK website or the British and Irish Hypertension Society website, they're both good for looking to see that you've got a validated machine.
Of course, the good news is that if detected, alongside a series of lifestyle changes, there are a range of medications available to clinicians to help us keep blood pressure within the normal range. And I know from previous conversations we've had, Pauline, you're keen to highlight that it's vitally important, if you have been prescribed medication for high blood pressure, you keep on taking it.
It is vitally important that once you're on established treatment, that you continue taking it. You have to make adjustments in your own way of thinking that this is a controllable disease, completely controllable, but it's only controllable if you have healthy lifestyle, modify your diet and take your tablets. I have seen many really sad cases of people presenting with severe heart failure, severe kidney failure, because they had been taking their tablets and then decided that they stopped taking them. Also, if you suddenly stop taking your medications, then your blood pressure will shoot up to what your baseline level of hypertension is, and that can be extremely dangerous. It's a really bad idea. So you have to, I think, encourage individuals to think about just incorporating this into their routine, like they would if they were taking a vitamin tablet, brushing their teeth, doing things to keep themselves healthy and well.
My grateful thanks to Dr. Pauline Swift. To find out more and to connect through to Blood Pressure UK, visit our website, wordonhealth.com. That's wordonhealth.com.
Word on Health, on air and online 52 weeks of the year with Paul Pennington. Word on Health, your personal prescription for your very best of health.